It's my pleasure to introduce Dr. John March. Dr. Marsh is a professor of psychiatry and psychology here at Duke. He is also director of the NSM department here at DCRI. Formerly chief of the Division of Child and Adolescent Psychiatry at Duke, he has extensive experience in cognitive, behavioral, and pharmacological treatment of pediatric and adult mental illnesses. He has a Career Development Award from NINMH for clinical trial methodology and is also a NARSAD Distinguished Senior Investigator. He's been principal or co-principal investigator for a number of NIMH trials, as well as being key in putting together the Child and Adolescent Psychiatry Trials Network, or CATM network, that we work on here as well. In his spare time, he's deputy editor of the Biological Psychiatry, member of the NIMH Advisory Council, and also in the American Academy of Child and Adolescent Psychiatry. It's a pleasure, Dr. March.
So I'm told that I have to stand on this thing, and that if I don't, Karen is going to whack me with sticks. So if I move off my appointed jail, see how far I can get. Please, look at me cross-eyed or something. So what I'd like to do today is to talk with you about new developments in the treatment of mood, anxiety, and obsessive-compulsive disorders in kids. And this is, in essence, a 20-year retrospective on the work that I've done as a clinical trialist in child psychiatry. My first mentor and still close personal friend, John Greist, said to me once when I was complaining about the fact, this was when I was a resident in psychiatry and was already being asked to give talks, when I was complaining about the fact there was no data and I didn't really know what I was doing, I was a resident, he said, go out and get the data, and in doing that, you will have something to say and you'll transform the field. And if you look at that, this is team science. I mean, there are hundreds and hundreds and hundreds of people that have been involved in these projects. But we have essentially asked and answered the major questions for intervention research in these areas in pediatric psychiatry over the last 20 years. So this is kind of a summation of this work that we have as a group done together. Oops, what did I do? Oh, I know what I did. I pushed the wrong button.
One on the right, John.
Okay. So these are my disclosures. I have done the best I could to hit the sweet spot in the conflict of interest story, which basically means collaborating with industry where it made sense to, and to staying out of promotional work. So I haven't been on a speakers bureau for over a dozen years, but I have extensive relationships with a variety of different companies, all of them around collaborative science. So the studies I'm going to talk about, or the work I'm going to talk about, has all been funded by the National Institutes of Mental Health. The NIMH made a strategic commitment 20 years ago to build the pharmacologic and cognitive behavioral monotherapies and then proceed toward comparative treatment trials. And the adult world was about 5 years ahead of the pediatric psychiatry world. I had the very good fortune at the beginning of my career, when it was clear that I would not be able to become a cognitive neuroscience. Cognitive neuroscience, by the way, wasn't invented in 1990. It tells you something about how the field has transitioned. I came here to do what has now become cognitive neuroscience and child psychiatry, which made it even harder. And when it was pretty clear that that wasn't going to happen, even though that was my first NIMH grant, I moved into intervention research on the multimodal treatment of ADHD study, the first large comparative treatment trial in child psychiatry. And all of those projects have been funded by the NIMH, and which has been a good place to be scientifically over the last 20 years. So why is it important to do work in kids? This is a slide, the table panel of which shows that if you were mentally ill as an adult, you were first mentally ill as a kid. About 50% of mentally ill adults were mentally ill by the time they turned 14, and three-quarters of them were mentally ill by the time that they turned 24. And if you take Alzheimer's disease out of the story, about 90 to 95% of mentally ill adults had their onset of mental illness some form of mental illness as children. So if we're going to make a dent in the landscape of mental illness, it's going to have to become it's going to have to start with kids. Now, this is actually something that everybody's aware of, not just from the epidemiologic data, but if you look at the risk genes that are being identified for mental illness of all different sorts, most of them are genes in neurodevelopmental pathways. That is, they specify the mechanisms by which brain cells divide, move to where they belong, and set up conversations. And that process, otherwise in an umbrella sense termed neuroplasticity, is also the mechanism by which we learn as we age from birth until death. So those 2 pointers are pointing us to a shift in the landscape of neurosciences medicine toward early developmental events, and will alter over the next 10 years child psychiatry in such a way that it moves actually to the forefront of the field, because that's where the action is going to be. Now, at present, if you're mentally ill, even though you got mentally ill as a kid, this is the right-hand panel, work from Phil Wong. The first work is work by Ron Kessler. You don't actually have your first encounter with the treatment system. That is, you don't get a diagnosis and start treatment until approximately 8 to 10 years after your mental illness begins. So the practice landscape in child psychiatry, even though what you're going to see is the best of what we do, the practice landscape is actually horrible. So most of you who have mentally ill kids or have mentally ill family members or know through your friendship networks mentally ill kids, most of them probably didn't get diagnosed properly for quite some time after their symptoms began, and many of them probably are not getting anything like the treatment that they would get if they were seen over in our Rutherford Street clinic, where you get the kinds of protocols in practice that we actually use in research. And that's the problem, as I see it, with the sort of challenge of mental health care, is to move the things that we know how to do in our boutique academic settings into the community so they're available widely for mentally ill children and adolescents. And part of the process of doing that is the move of clinical trials out of the research clinic and into practice settings, as we're doing on the Captain Network. So a pointer to all of this, if you'd like to actually see where the field is going, the marriage of developmental neuroscience with developmental epidemiology with interventions research, is a work group I chaired with Pat Levitt, who's a developmental neurobiologist. Last year published as a council work group report called Transformational Neuroscience and Mental Illness. Kind of lays out the roadmap for where the field is going based on the revolution in genetics and the development of new molecular targets and new drugs and overlearning strategies that allow the brain to heal itself in the same way that someone in an orthopedics clinic would receive physical therapy. These are the models by which psychiatry is going to progress, and you can get a sense of what this landscape will look like going forward by reading this report. So the comparative treatment trials that we're going to be talking about all use this hybrid design. They have to, oops, sorry, you can't see that thing, right? Why am I pointing at that? There are prerequisites for a comparative treatment trial. You have to have the assessment methodologies set up. So you need to have a well-defined, psychometrically validated clinical trial endpoint, and you have to establish the validity or effect sizes for the monotherapies. You have to know that the treatments, individual treatments that you have work. So those randomized controlled trials have to have been completed. And then you can move to a design which compares a medication strategy, a cognitive behavioral psychotherapy strategy, their combination, against some sort of control or comparison condition. And as I said before, I started in this world with the MTA study. What we're going to be talking about is the Pediatric OCD treatment study, POTS 1. We're currently finishing up POTS 2, and we're beginning POTS Junior. The treatment of adolescent depression study, which we coordinated here, and the child-adolescent anxiety multimodal study, CAMS, which was published in the New England Journal in December. We're not going to talk about the treatment for adolescent suicide attempter study that has not yet been published, but if you'd like to talk about suicide in kids, I'm happy to talk about that in the discussion section. So Elias Zerhouni, who has stepped down now as NIH director, said we're in a revolutionary period of medicine that I call the 4 Ps: predictive, personalized, preemptive, and participatory. We are a long way from this vision, even though this is where the field is going to go. I don't think it actually, in a clinical trial sense, makes a lot of sense to think of impacting practice from a personalized medicine point of view. But I do think it is important to move the field toward personalized medicine and the kinds of research that we do. And this is why. These are Kielin's forceps. Anybody know what these are? So one person. So I was a family doc before I became a psychiatrist. And in this little town in Montana that I was a family doc for 5 years, one of the things I did was deliver babies. So between my residency and my when I left Hardin, Montana as a family doc, I delivered about 500 babies, including doing 120 C-sections. And as part of that, I did a lot of forceps rotations. And what happens when the baby comes down the birth canal and gets stuck, what's called occiput posterior, and nose pointing up instead of down, is that you have a baby that's in the birth canal and won't move. And so you put these forceps around the baby's head, and you turn the baby's head from occiput posterior to occiput anterior so the nose can slide under the pubis and the baby comes out. And if you do that well, you avoid a C-section and you have a healthy mother and a healthy baby. The problem is that it works very well in people that do a lot of these and are good at it. Every time I did it, it scared the hell out of me because I did do a lot of them and I wasn't particularly good at it. And that, unfortunately, was the case for a lot of OB/GYN. They were trained to do it through residency because everybody got sectioned. And there were a lot of people out there like me as family docs delivering babies, and surgeons and other people who didn't do a lot of OB. So the field made a principled decision to move to C-sections, reduce the heterogeneity of practice. Everybody did the same thing. It was easy to standardize. C-sections are easy to do. They have almost universally good outcomes. And the field rapidly made this transition, and maternal and fetal morbidity and mortality went way down as a result. And if we just did that in psychiatry, we moved out into practice, the best of what we have available to us, the public health would rise dramatically. And hopefully, as we transition to an electronic health record and we have a president who likes science instead of one who isn't guided by science, we'll begin to see these kinds of models move into the healthcare system, not just in psychiatry, but more widely. So if we're able to do that, if we're able actually to disseminate interventions that work so that practice truly becomes evidence-based, it will be around studies like the ones I'm going to talk to you about. So let's talk about OCD. Actually, do you all know what OCD is? This talk is designed to be given to mental health practitioners, so maybe I should say a little bit about the disorders. OCD is a disorder which typically begins in either childhood or adolescence. It involves obsessions, which are intrusive thoughts, ideas, images. They come into mind unbidden. They're unwanted. They produce bad feelings. And in response to those unpleasant thoughts and bad feelings, the patients who have this, or persons who have OCD, it's kind of like your brain hiccups, do things to make the bad thoughts and bad feelings go away that we call in OCD rituals or compulsions. So as an example, somebody says, if I touch this bathroom stall on the way into the bathroom, I'm going to get germs on me, and if I go home, I'm going to give these germs to my daughter, and my daughter is going to get some horrible disease and die, and it will be my fault. So the obsession is a germ fear. The ritual is washing, which she does when she comes out of the stall, and she's trapped in there for an hour. Everybody in this building has probably come out of a bathroom and seen a pile of papers by the door. That person has OCD. They didn't want to touch the doorknob as they went out because they'd already done a bunch of washing rituals. So about 1 in 100 people has this. It's one of the more common, one of the less common, but more disabling disorders in psychiatry. And kids have it. It begins in childhood. If you have it as an adult, it was pretty likely you had it as a kid. So when I started my training, everybody was being treated with psychoanalysis, and I had the good fortune to be involved in the first clomipramine, or anafranil, adult and pediatric trials, which Joe DeVogais was actually heading at Ciba Geigy. And the kids coming out of those trials would have gotten family therapy or psychoanalytic psychotherapy, but everybody knew that those things didn't work. My analytic supervisors wanted me to do that, but I tried it and it didn't work. And so I went to Edna Foa, who was one of a pioneering generation of psychologists that were developing cognitive behavioral interventions for OCD. And Edna said to me, my second great mentor, said to me, why don't you develop a developmentally sensitive version of OCD for kids? And so we did that, and we ran a study which was actually done here when I came to Duke, comparing, looking at CBT in an open pilot, seeing if we actually could reduce symptoms of OCD in kids the way that it worked in adults. And these were kids, most of whom had been in the sertraline pediatric OCD study, which I'll tell you about in a moment, who were quite sick. They actually had started up here. They got a little bit of a bump from medications, but down here is normal. And over 12 to 16 weeks of cognitive behavioral therapy, when we were first actually learning how to do it, they went down to the remission threshold, and they stayed well at follow-up intervals out to 2 years. So we had some sense that you could do this using a protocolized form of CBT in children that would be as effective as working with adults. We published this subsequently as a book in 1997 or 98. And as we moved this research agenda forward, we were also doing the sertraline pediatric OCD study, which I wrote up with collaborators at Pfizer in 1998, published in JAMA. And in this study, which was a conventional randomized controlled trial, we compared sertraline to placebo over 12 weeks. And you can see here, not much placebo response, pretty robust drug response. This is about a 30% improvement, which represents 6 points on this scale of OCD called the Yale-Brown Obsessive Compulsive Scale. What this slide doesn't show you, because it's a change score, is that if you start at 28 and you improve by 6 points, you're at 22, which is still moderate to moderately severe OCD. Put myself back on my spot. Am I doing okay? Which is, while it's meaningful improvement, it takes 18 to get into the study in the first place, and 10 as the remission threshold. So these medicines, and this is true across all the adult and child trials, these medicines hit singles, occasionally they hit doubles, very rarely they hit a triple, and almost never hit a home run. So what we knew is that the medications worked, but they didn't work very well. CBT seemed to work, but we didn't have a randomized controlled trial. And so we set up the POT study, which is a comparison funded by the NIMH of cognitive behavior therapy using our protocol, sertraline, and their combination for children and adolescents with OCD. This was published in JAMA in 2004. And is really the pivotal trial in this particular area in pediatrics. And the results were actually really quite striking. These are random regression analyses with the child Y box on the y-axis and weeks of treatment on the x-axis. And you can see here, this is placebo, not much placebo response. This is sertraline and CBT. They actually tied on the random regression analyses. This is the combination of the two things, which takes kids down to the remission threshold. Now remember, 10 years earlier when I started training, people felt like these kids were very rare and were untreatable. So over a course of 10 years, we were able to develop a technology which allowed half these kids to normalize within 12 weeks of treatment. And this is still true. If you are a kid with OCD and you come into my clinic over at Rutherford Street, and we have many of these kids who've been treated for years with various forms of one thing or another, we will have you 50 to 60% of the time well within 12 weeks, within 3 months, and many kids just with CBT alone. You can see this a bit more clearly, actually, if you look at the remission data. This is now looking at X-in response, or a Y-box score below 10. Nobody gets normalized for wishing it was so. About a fifth of the kids normalized on sertraline, 39% on CBT, and over half normalized with a combination of CBT and medication. So the treatment of choice for this disorder should be CBT, unless you're really sick, CBT plus meds, or if you're not rapidly responsive to CBT. And why this is important is that CBT is carrying the variance in the treatment for OCD. It's what works. In depression, you'll see in a moment, at least acutely, it's actually medications that carry the variance. So Lyell's fundamental observation is the most important leg of the three-legged stool is the one that's missing. And you cannot get this most places in clinical practice, which I think is more a reflection on the practice community. Practice community's unwillingness to do things that work in order to hang on to things that don't work because they like them. One of them being lots and lots of different medications. The other being various forms of non-effective psychotherapy. So we wrote a book called Talking Back to OCD, which was published 2 years ago, that essentially is John March at your kitchen table. I took everything I knew about OCD and wrote it up as a manual for parents and kids with OCD as a kind of a self-help guide. And I get emails every week from around the world from people who've used this, who didn't have access to good care, who have successfully gotten rid of OCD using a self-help format. Eventually, this will be streamed over the internet, and you won't have to worry about going to see your doctor to get it. Now, one of the things that we want to know on the way to personalized medicine is which child should get which treatment. Are there treatments that work well for some kids and don't work well for other kids? And so we looked at the POTS data with respect to whether tics made a difference, because a lot of the kids with OCD will also have tic disorders. And it turns out that it actually does make a difference. This is a replication of earlier work by Dan Geller, who showed with paroxetine that kids with tics didn't respond to medication. They were no different than placebo, where kids without tics that had OCD benefited from the medication. So if you look here, this is now your week 12 Y-box score. So bigger is actually worse in this slide. And you see the same trend we talked about before. Nothing happens with placebo, not much happens with meds. CBT does better, and the best treatment is combination. But look here in the kids with tics, in the same way that Geller found with paroxetine, tics don't make you non-responsive to medication. We found the same thing with sertraline. So in this particular patient population, you should actually not get medication. You should get cognitive behavior therapy. And there are forms of CBT that work very well for tics. So in a disorder which most of us think is neurological, one of the poster childs for neurobiological forms of mental illness, it's in fact the cognitive behavioral treatment which is more effective as contrasted to medication. Now, the adverse events for this, all treatments come with side effects. It's true in neurosciences medicine as in the rest of medicine. These drugs were tolerated very well, mild nausea, in some cases diarrhea. A few kids got activated. Nobody got manic or suicidal, and there were no serious adverse events in this trial. What about adolescent depression? David Brent did a very nice study showing that cognitive behavioral psychotherapy was superior to nonspecific supportive psychotherapy and also kind of existentially oriented family therapy, the two modalities which are most commonly available in the community. These are supportive psychotherapy and family therapy. This is CBT at 16 weeks. CBT is clearly much better than the other two modalities. This is a study done by Graham Emsley in 1997 and replicated in 2002, looking at fluoxetine for children and adolescents with depression. A much bigger placebo response in depression than in OCD or in anxiety disorders. We can talk about the reasons for that if you'd like to. And a nice, robust drug response for fluoxetine. These trials were coordinated in the way that we would coordinate them here, which is why the placebo response wasn't as robust in these studies as it is in other studies. In other words, it's method variance that accounts for so many failed trials in depression, not whether the drug works or not. So these were two very good studies, and coupled with the Brent psychotherapy study, the NIMH felt it had a reason to go ahead and do a comparative treatment trial looking at CBT, fluoxetine, their combination, and pill placebo as a control condition. Now, I want to illustrate this point again about the nature of the placebo response. This is a study done in sertraline, published by Karen Wagner in JAMA, and you can see here that the drug effect was about the same as with fluoxetine. The placebo response was much more robust. This trial was coordinated by a commercial CRO, and the difference between this trial and the fluoxetine trials was all method variance. So we were funded to do the TADS trial. This is actually a funny story. This was a setup. The RFA for the contract was a setup for David Brent's group at Pittsburgh. And I just wanted to be a site on David Brent's study. So, but Ranga Krishnan, our department chair, said, "You should apply for this." So I called David up and I said, "I've been told I have to apply for this." So I hopped over here and applied for it. And assuming that we wouldn't get it, that David would get it, and if we were lucky, we could play a role, either DCRIY or at least I could be a site on the study. David looked at the contract provisions. The science is 25 pages. The contract was 600 pages, and threw up his hands in horror and said, "I can't possibly do this." And so, because of the resources and expertise and professionalism of the DCRI, we were awarded the TADS contract, which is a really pivotal landmark study in this area, which is still publishing papers and has dramatically shifted the discourse in the field around treatment of adolescent depression. So the sample in the TADS, this was a paper authored by Susan Silva, set the frame for the study. And you can see here, these were sick kids. The cognitive behavioral psychotherapists who were on this trial, principal investigators in some cases, said they'd never work with kids this sick. So these kids were markedly to severely ill. They'd been sick for over a year, some of them as long as 5 years. They had multiple comorbidities, including ADHD. 15% of the sample was taking stimulants. So this is a really sick bunch of kids, the kind of kids that nobody would argue about whether they needed treatment or not. We published the result of the short-term acute outcomes comparing fluoxetine, CBT, their combination, pill placebo as a control, in JAMA, again in 2004. So the Duke University had 3 JAMA papers in 2004. One of them was the Hypericum study, which was coordinated here. One of them was the TAD study coordinated here, and the other was the POT study, which we ran out of Rutherford Street. So you can get a sense of the sort of importance and impact of this work. And this is the result. Exactly the opposite story from what we found in pediatric OCD. This is the Children's Depression Rating Scale on the y-axis, baseline week 6 and week 12 on the x. This is the starting point, moderate to severely ill on the CDRS. This is placebo and CBT. No difference between CBT and placebo. This is fluoxetine in combination. While this is a 10% difference, it was not statistically significant. So here, what made a difference if you were a really sick adolescent with depression is getting medication, where in OCD, if you were a really sick kid with OCD, what made a difference was getting psychotherapy, getting CBT. If you look at response, this is now much or very much improved. The story is the same, though, with the sense that we can help lots and lots of kids in a relatively short period of time. Remember, these kids were ill on average of 1 year, some as much as 5 years. So it wasn't a matter of just kind of wishing away the illness. 70% of the kids normalized with the combination, or not normalized, but were much improved or very much improved. 60% with fluoxetine, 43% with CBT, and about 35% with placebo. So again, a big placebo response in depression, which is interesting to think about, but nothing like the 50% placebo response rate you see in the failed trials. If you summarize the significance testing, you really see an advantage for combination treatment. There were 16 different endpoints you could look at. This would be endpoints in the sense of like function or quality of life, or endpoints that were determined by the perspective of the person who was responding, the adolescent versus the parent versus an independent evaluator. And virtually 100% of the time, combination beat placebo and beat CBT. It beat fluoxetine half the time. Fluoxetine only beat CBT half the time and only beat placebo half the time. So here, if you look at the whole child, there's a real advantage for using the combination treatment rather than just going with medication management. Adverse events, again, were pretty similar. We had no mania and no non-harm serious adverse events, and I'm going to talk to you about suicidal events in a moment. Oh, actually, here's the adverse event story with respect to how it broke out by treatment group. This is fluoxetine. 11% of the kids had adverse events on fluoxetine. This is combination. This group also got drug at roughly the same dose. About half the kids on combination, or half the number of adverse events on in the combination group as compared to the fluoxetine alone group. So there's something about getting CBT that reduces the noxious side effects of these medications, brings them down, in fact, to roughly the placebo response rate. We look now at a whole variety of other outcomes in a special section in the Child Psychiatry Academy Journal, and I'll run through these really quickly. This is quality of life. These are the three monotherapies, placebo, CBT, and fluoxetine. If you pull fluoxetine baseline down to here, it's in the same lineup as these guys. Big improvement in quality of life from the point of view of the adolescent. Same thing is true as functioning. This is percent of kids who were no longer impaired. There was still some impairment at 12 weeks, actually. Only about 34% of the sample was non-impaired in combo. No difference between placebo and fluoxetine or CBT. Reasonably meaningful improvement with combination. Now, we want to know who gets better. One of the really interesting things in psychotherapy is that if you're a kid from a two-parent family and you have a lot of income so you can get the best available care, it's a very robust finding, and you're smart, you tend to do pretty well with psychotherapy. What we found in the TADS trial, and this was independent of family income, is that kids who had who were from high-income families actually did as well with CBT as they would do with medications alone. So this subgroup of kids may actually be good candidates for starting with CBT rather than starting with medications. But again, the combination treatment is still better than either monotherapy. Now, one of the things in depression is that you don't normalize everybody if you just stop at 12 weeks. So we thought if we went longer, if we did 9 months of treatment rather than 3 months of treatment, maybe we could normalize a substantially larger number of kids. And in fact, that happened. And it says something that we didn't anticipate that was really important in the way we think about treatment for adolescent depression. So this is response rate on the CGI-I, the Clinical Global Impressions Improvement Scale. This is the number of patients responding, much or very much improved on the y-axis. This is week 12, this is week 18, and this is week 36. And all this scrambled eggs for legends is what happens when you move from the PC to the Mac when you generate these slides. So this is the data you've already seen. Combination is better. Here's fluoxetine, here's CBT, here's placebo. Placebo kids went out into open treatment at 12 weeks, so they're not included at week 18 or week 36. Here's combo at 80% response rate at week 18. CBT now catches up to fluoxetine, which is just what you would expect because all the CBT studies went out to 16 to 18 weeks. Everybody knew that it worked more slowly. And now you see out here that all of the treatments come together with a non-statistically significant advantage for combination treatment. These two treatments, CBT and fluoxetine, it took between weeks, it was around 28 weeks, maybe 30 weeks before those two treatments got to the point that they were at the same level as combo. So with combo, you get there at 18 weeks. It takes another 3, maybe 4 months to get there with the two monotherapies. So another advantage to the combined treatment is not just it's not how well you get, it's when you get there that matters, speed of response or when you reach maximum medical benefit. This paper has now been submitted. It will actually, it's been accepted pending a few revisions, looking at the data over 1 year of naturalistic follow-up. Now, why is this important? It's important because the view of the field has been that if you treat somebody with depression and you don't continue the treatment, they will relapse, usually within the first 6 months. So all the data from the epidemiologic studies and from the treatment studies showed that depression was a waxing and waning illness, and that if you stopped treatment, the probability was 50% or greater that the patient would relapse within the first year after stopping treatment. Well, that didn't happen when we looked at the TADS data. So this is, again, week 6, week 18, week 36. So this is where the previous slide ended. And you can see for all 3 treatments, if you treat patients as close to remission as you can get, they stay well for an additional year. So what we showed, which I think is, from a public health point of view, very important outcome, is that it takes longer-term treatment in order to produce stable remission. And this makes perfect sense from a neuroscience point of view. If you want to generate new neural circuits or reinforce neural circuits which are hiccuping so that they can function normally, that is, consolidate the benefits of acute treatment, that process takes a considerable period of time. In order to consolidate a normal neural circuitry, a normal sense of perspective from a cognitive point of view, one needs to treat people for up to 9 months. That short-term treatment simply will not do it. This is the remission data. Essentially tells the same story, although fewer kids in remission than responding. Turning now to anxiety disorders, it's essentially the same model. This is data. These are now social anxiety disorder, the quintessential phenotype of which is difficulty talking to someone else, whether individually or in public. Separation anxiety disorder, which is this, essentially it's panic disorder in little kids. You feel like the world is going to fall apart if you're not in a teacher or a parent's lap, and you want to stay in a kind of a safe place. It's all the alarm systems going off to produce panic level symptoms when they're not supposed to. And generalized anxiety disorder, which is the Chicken Little kid. Sky is falling, the sky is falling, everything is going to fall apart, I don't know what to do. So these 3 disorders account for the majority of kids with typical anxiety disorders, kids with true panic disorder, the simple phobias, and so on. Typically, the latter don't get treated. The former is a relatively small percentage of kids with anxiety disorders. So this was data from Phil Kendall using a cognitive behavioral manual called the Coping Cat. And in 2 studies, one in 1994 and one in 1997, he showed that you could improve the lives of kids with anxiety disorders in kids who got the cognitive behavioral intervention as compared to kids who were put on the waiting list for 12 to 18 weeks. And that result then was replicated again in a second study. So we had a CBT for anxiety disorders. We also had medications. This is a paper that we did on the research units on pediatric psychopharmacology, published in the New England Medical Journal swimsuit edition. Sorry. In 2001, we used fluvoxamine, but my view is that all the SSRIs are the same. If you ran them head-to-head, there wouldn't be a dime's worth of difference between them. No placebo response, nice drug response. About 60% of the kids responded at the end of, in this case, 8 weeks of treatment. So we had a CBT monotherapy and a med monotherapy that we knew worked. And we built the CAMS trial, which was actually coordinated between Duke and Johns Hopkins University, using the TADS as a model. What you see here in this slide is basically that, like the TADS, this was a very sick group of kids, much sicker, again, than the cognitive behavioral psychologists were used to seeing in their CBT protocols. And if you look at treatment response, the results look like fake data. We hypothesized 80% response rate in combo, 60% for the 2 monotherapies, 40% for placebo. And the only thing that was wrong about that was the placebo response rate was 24%, which is probably because the study was well done and because these were really sick kids. 80% response rate in combo, 60% in CBT, 55% with medication. This guy beats these 2. These 2 don't separate. And all 3 of the active treatments beat placebo. Adverse events were pretty much like you would expect. Again, this study was done with sertraline drug and matching placebo from Pfizer. There were no kids who got manic and no suicidal events in this trial. Now, in the MTA trial, the ADHD trial, about 25% of kids with ADHD will have an anxiety disorder. Half of them, more than half of them, 2/3 of them with conduct problems, ODD or CD, and about 11% with just a comorbid anxiety disorder. Anxiety in this sense is probably reflective of negative parent-child interactions more than it is the kind of kids that came into TADS. If you're around ADHD kids very long, you know they get inconsistently punished all the time, and so they're always watching out for when the shoe is going to drop. It's sort of a function of the nature of the disorder and the environment that they live in. So there are some truly anxious kids in here in the sense of having syndromal anxiety like the CAMS kids, but a lot of these kids were basically just living in a very fearful environment elicited by their disorder and the kind of ineffective parenting strategies that their parents used to manage the disorder. And if you look at the result, the without anxiety group is the overall result from the MTA. This was a comparison of Ritalin and very intensive cognitive behavioral intervention that included 57 weeks of parent training, an aid in the classroom, and a summer treatment program, medication alone, and medication plus the behavioral intervention. So you see here that that great big gigantic behavioral intervention was about as good as getting an insufficient dose of Ritalin from your pediatrician, and there was no advantage to the combined treatment as compared to just getting medication in kids with ADHD between the ages of 6 and 9. Most kids will do quite well with uncomplicated ADHD just with medications and will not do very well with a psychosocial intervention. On the other hand, look at the kids who had comorbid anxiety. This is the little Ritalin from your pediatrician group or family doc group. This is the cognitive behavioral intervention, the big hit. This is medication alone, and again, now here's the combination treatment. So the more complicated kids really do benefit from getting the combination of medication plus a psychosocial intervention, an evidence-based psychosocial intervention. And because the community is full of all kinds of complicated kids, we typically recommend for ADHD kids that you start with stimulants, and for kids that are more complicated that you get a psychosocial intervention, usually parent training on top of it. Now, you all know, can't avoid it if you don't live in a sensory deprivation chamber, that antidepressants somehow, through some mechanism, promote suicidal events, defined as a dramatic increase in suicidal ideation, dramatic and alarming increase in suicidal ideation, an interrupted attempt, somebody tackles you right before you pull the trigger, or an actual suicide attempt. So these are alarming events. There are about 2,000 suicides every year in kids in this country. There are about 2 million suicide attempts that result in some sort of encounter with the healthcare system. Many of you probably have either children or family members where there's been a suicidal event in your family. These kids dramatically alter the way families work and feel about themselves, and have a dreadful impact on the life of the kid, because everybody's always looking at them as though they're about to do it again. So this is a really important public health problem. So are these really teen suicide pills? And there are people still in the field who argue that this is an artifact. It doesn't happen. We shouldn't. The black box warning was a mistake. I tend to take the opposite point of view. This is the Tariq Hamad slide at the FDA hearing that led to the black box. This is the TADS trial. It is the only non-industry trial that made it into this data set, which actually tells you, I think, something important about the DCRI. Because the work that we do here follows FDA audit rules and people look to us as high quality, the FDA felt like it was reasonable to pull this data into this evaluation, where all the other trials that were done by NIMH-funded researchers or people doing their own studies were disallowed from this particular evaluation. But the take-home message is, if you take all these trials, if you just looked at one of them, you'd say, well, you know, you can flip a nickel, and sometimes you get 4 heads, and sometimes you get 2, and you know, it's just chance. But if you line all these studies up, and you look at all these relative risk ratios to the right of 1, that is, there's a small effect, the data becomes convincing that, in fact, the drugs are doing something. So what does that mean? It means if you have 200 kids, 100 on placebo and 100 on medication, you'll have 6 suicidal events. 4 of those will be in the active treatment, 2 in the placebo. 2 of them in placebo means that 2 of them in the active treatment would have happened anyway, so 4 of the 6 would have had it without the drug effect. this is an NNH of 50. The actual NNH is probably closer to between 100 and 150, number needed to harm. That means you could never pick this out in clinical practice, this small drug effect. In fact, most of the kids would have had it happen anyway. And half these kids would have been drunk or stoned at the time, and virtually all of them would have been in a big fight with somebody or other right before the suicidal event. So those people who tell you that the drug did it, which is all the Scientologists, are full of baloney. But nonetheless, on a population basis, this effect actually is quite worrisome. Now, you can eliminate this effect by combining medication with CBT. This is the extraordinary result, if it's replicated, if it holds up from the TADS. This is data on suicidal ideation, looking at who tripped the suicidal ideation questionnaire flag at baseline in week 12. You can see the combo kids, 40% of them tripped the flag. Randomization didn't work on this variable. So this means that you have sufficient suicidal ideation to need prompt clinical evaluation. There was a lot of it, about almost 30% of the sample at the start of treatment. It went way down with treatment, and it didn't go down as much in the kids who got fluoxetine as compared to the combo kids. So there's something about combining CBT with fluoxetine that ameliorates this fluoxetine-associated increase in suicidal ideation and events. If you look at events, it's actually even more striking. So this is now looking at the suicidal events across the first 12 weeks of the TADS. 11% of kids in fluoxetine, 1 in 10. And remember, this is now in kids that were watched like hawks. We had a suicide prevention manual. They were getting the best of available treatments. 1 in 10 still had one of these events. The risk went completely away in the sense of excess risk if you combine CBT with medication. The same result actually held true if you looked out to 36 weeks. Now, what does this mean in terms of suicidal events and actual completed suicide? You remember I said there are 2,000 deaths by suicide among children and adolescents each year, and 2 million suicide attempts. And these are different things. A completed suicide is not the same thing as a suicide attempt. When the black box kind of came along the year before and the year of the black box, which was actually in 2003, prescription rates for SSRIs went way down, and they went most dramatically down in children and adolescents. They didn't drop at all in the geriatric population. Now look what happened here. Here's the beginning of the warnings. Here was the black box in 2003. 25% more deaths by suicide in 2004 than in 2003. So although there might have been fewer suicidal events, it also increased the death rate. So how do we make sense out of all of this? Well, one way to think about it is that suicidal events are more common in depressed kids than kids with anxiety or OCD. Remember the OCD and the CAMS and the POTS trial. We basically didn't see this, but we saw it in 1 in 10 kids in adolescent depression. Antidepressant speed recovery improved functional outcomes, especially if combined with CBT. Antidepressants slightly increased the suicidal event rate. Given 2 million events, that's a really important public health problem. You can't see this, but basically if 1 million of these kids had a mood or anxiety disorder, 500,000 of them were on medications. The number needed to harm was 100. That means there are 5,000 kids who land in ERs each year in this country as a result of taking an antidepressant for a mood or anxiety disorder. Antidepressants prevent death by suicide, probably by effective treatment for depression. And if you co-administer CBT, you can wipe out all the excess suicidality. So if it happens, it's not happening because of this drug effect. So people like to poo-poo this because it has enormous public health implications and say it needs replication. And it hasn't shown up in a couple of other studies, probably because the samples were different. But this was unanticipated, and I think is actually one of the most important findings from the TADS. If people took it seriously, it would dramatically change the way we do practice. Now, we've learned a lot, but not nearly enough. We've got too few, mostly acute studies. We don't ask the questions that are of interest to decision makers. They lack generalizability. These are still research-based studies. They don't adequately assess safety or moderators because they're basically not large enough. They're very expensive and take a very long time to complete. The TADS cost $70 million and took 7 years. And most importantly, they're performed long after the treatments are already in clinical use. This is true on the med side, less so on the CBT side. So we needed to figure out something to do about this. Oops. And so I decided that, thinking forward, we needed to move to practical clinical trials like you'd see in heart disease or in cancer. This is the definition of a practical clinical trial from Richard Pito. Always larger, almost always larger, always simpler than typical randomized controlled trials, aim to provide reliable estimates of health outcomes applicable to a broad patient base under usual clinical conditions without bias. Mostly the without bias is because of introducing randomization. So these are trials that are designed to run in practice settings. And so we built a rationale for this and a series of papers that actually were the first papers on this topic in psychiatry. And then we built a practical clinical trials network, the Captain Network. We're doing several studies. This one is a registry looking to see if we can identify who's at risk for having one of these suicidal events with antidepressant treatment. And unlike the TADS, where the suicidal event rate was around 10%, we're running a suicidal event rate which is closer to 30. And some of these kids are actually getting CBT, although many of them are just getting medication management. So this problem in clinical practice is actually far worse than it looks like from our randomized controlled trial data. That trial is about to close enrollment, and we should have the answer, or some of the answers, when we reach the data analytic stage this summer. So Mark Twain, a man who carries a cat by the tail learns something he can learn in no other way. Medication with an SSRI or CBT are effective. Combination is probably the best treatment for the average patient. And one thing I didn't show you is if you look at these trials, they all have significant site-by-treatment interactions. That is, at some sites, medication works better. At some sites, CBT works better. At all sites, placebo comes in last and combination comes in first. Now, what does that mean if you think about the implications for clinical practice? It means if you were going to disseminate a strategy, you'd want to disseminate the combination treatment because it takes out all the variances associated with site and patients and doctors. The combo always wins. It doesn't matter where it is or who's doing it. The combination treatment is always better. For depression, longer duration treatment is the best path to recovery. Medication-associated suicidal events are more common in depression and might be eliminated just by adding CBT. Taken as a whole, the data show that identification and treatment of these disorders and treatment should have a very positive public health impact. And I like to say, while not yet a standard of care, the evidence is strong enough to support mentioned during the informed consent process. I would hate to be a doctor who used a complicated polydrug regimen in a kid with OCD with a disastrous outcome and never mentioned cognitive behavioral psychotherapy. I think that's, at this point of time, given the quality of the data, is malpractice. So these are the funding sources. As always, this is a team sport. There were lots and lots and lots of people, including people who work in this building, that contributed to these studies. They've been funded by a variety of funders, mostly the NIMH. And if there's any merit to this, and I really mean this, if there's any merit to this, it doesn't belong to us, it belongs to the kids and families who participate. The whole edifice of medicine is built on a very small number of researchers working with a slightly larger number of patients. The only area of medicine in which all the patients are also research subjects is childhood cancer. And in childhood cancer, 25 years ago, 95% of kids died because with acute lymphocytic leukemia. Now 95% survive 5 years, some of them because they're seen in the bone marrow transplant program here. If we were able to do the same sorts of things, which everybody in this room is invested in doing, in mental health care, it would totally transform the field to the benefit of our patients. Thank you. So if you have a sense that there's a mission in here, there really is a mission in here. What we do here is actually important. So it's time for some questions. Please.
Do you know why there's a difference Do you know why there's a difference between the response in the OCD and depression, as far as why would the medication work more in the depression as opposed to the OCD?
So the question is, why is it that a learning-based intervention works better in OCD? This is to paraphrase, where a medication intervention works better, at least faster, in kids treated with depression. If you look at the neural circuitry that's involved in the disorders, it's actually quite different. So the neural circuitry that is involved in depression involves the medial prefrontal cortex telling the anterior temporal lobe, particularly the amygdala, to shut up when it gets emotionally aroused in the context of a stressful or noxious life event. The neural circuitry for OCD is involved with regulating automatic behavioral response, basically habits. So it runs from an area of the brain called the striatum, which is where the stop signal for automatic behaviors resides, and the orbital frontal cortex, which is where complex worry resides, disgust, sort of worry about harm, the feeling that things have to be kind of balanced or symmetric when you look at your house and it's, it's kind of messy and not quite right. That feeling lives in the orbital frontal cortex. So they have two different circuits, and those circuits have different pharmacoanatomy. The pharmacoanatomy of the circuitry that involves prefrontal cortical regulation of the amygdala has a different pharmacology than the circuitry that's involved in striatal orbital frontal cortical dysregulation. So it's not much surprise that the treatments might be different because they're really different illnesses, in the same way that a brain tumor is different than, say, ovarian cancer. They both infect the brain. They both have certain things in common, but they're in some ways actually quite different. Different illnesses with different genetics, different biological pathways, and so on. And if you watch what's going to happen in the field in 10 years, between 10 and 15 years, neuroscience is going to explode in size. It will become as big as all the rest of medicine put together. And what we now think of as psychiatry as one division will have things in it like disorders that involve psychosis, bipolar schizophrenia, odd thinking, autism, will be a department in the same way that cardiology is a department, and it will have subspecialties and the whole gamut of things. And all this is going to be driven by progress in science. Bart? Oh, okay, please.
Can a patient with depression be cured or recover 100%?
Yes. The question is, can people recover? Recovery is a tough test. You'd like to believe, depending on your definition, that recovery means that you've been well for a year. Some people would say 2 years. That you're essentially robust to life stress. That's the goal. That is obviously the goal. If I can have an intervention that works, as we have now, a drug called ketamine, can take treatment refractory patients with depression and have them essentially non-depressed in about 6 hours. The problem is that you have to do it the next day and the next day and the next day. And giving somebody IV ketamine isn't actually easy to do or pleasant. It has a lot of risk. So as a clinical treatment, it's not very useful. The goal is an intervention that works in a hurry that has stable benefit over the long term. This will not come with any of the current generation treatments. CBT will be part of that because CBT is essentially physical therapy for your brain. It uses learning strategies, which is how the brain changes. It learns to be different. In the same way that you have physical therapy and endocrinology clinics for people with diabetes, not physical therapy, nutritional therapy, or physical therapy in a rheumatology clinic or an orthopedics clinic, you'll have CBT, which looks a lot like the CBT we have now 30 years from now. The drugs will be completely different. Some of the current generation drugs may still be around, but once we understand from the genetics what the molecular targets are in the sense of a pathway, the genes may not be the targets themselves, but they tell you what the pathways are. And once you understand the pathway, you can figure out where the low-hanging fruit is, how to bias these pathways toward more normal function so that you can rescue the pathway. And when you rescue the pathway, the phenotype normalizes. Those things actually have the promise of leading to recovery. Now, it may mean you need to take the medication your whole life. Ideally, what it will mean is that you'll get to it as early as fetal development, that a mother with a kid who's at risk will get the drug during pregnancy, and the brain will grow up from the first day of conception forward so that it is robustly protected from developing mental illness. That's the holy grail. I don't think we're going to get there anytime soon, but that's the model. Bart?
John, a lot of your data presented that the combination therapy works better in all cases, and I just wondered what your thoughts were on the field changing and I guess mental health being recognized and with less stigma, and that cognitive behavioral therapy becoming more sort of normal, for lack of a better term, treatment for anyone, really.
So this is, the question is, how can we make evidence-based treatment, whether it's drug or cognitive behavioral, available to everybody? And as part of that, how do we reduce the sort of stigma of getting treated for being mentally ill? They're really, in some sense, linked questions, but different. So the dissemination question depends, I think, largely on funding. If the government basically said, we're only going to pay for this, we're not going to pay for that, essentially took non-evidence-based treatments out of the insurance system, then you'd find a lot of people that were saying they were doing CBT but actually weren't. But if you now link these patients out of solo doctor's office and put them into groups, and you said, we have site monitoring for you, so that systems of care have to provide the interventions that are known to work, then we would see a pretty dramatic switch to evidence-based treatment. And you say, well, that could never happen. It's exactly what Spain did 10 years ago and the United Kingdom is doing now. Basically, these countries said, we're not paying for anything but CBT. Those of you that say that, or those people who say that there are lots and lots and lots of psychotherapies that work, and we should keep doing psychoanalysis, and we should keep doing systemic behavioral family therapy, and we should keep doing EMDR, and we should keep doing thought field therapy, and there's about 500 different named psychotherapies. To the extent they work, they all look like CBT. They have the active ingredients that are in CBT. The horse race is completely over. I mean, there's nothing at all that can contend with CBT, no matter what you call it. And that's because it's tightly coupled to its targets. That's why it works, because it looks like physical therapy. So it's a political question. Now, stigma is both an effectiveness question, and I think part of the answer to this is just disseminating practical clinical trials of these things so we learn how to disseminate them, and the trials themselves change practice because people who participate in research are more likely to live by the results of the research. Stigma is a separate thing, and we live in a very unfriendly culture. Everybody's supposed to be the valedictorian of their high school class and have straight teeth and blonde hair, and I mean, we're moving to a blonde hair isn't right because we're moving to a globalized world, fortunately, but there's still a lot of stigma around people with mental illness, and part of that is because, what do you do if you had a heart attack? So if I had a heart attack right now, right, you'd all jump up and try to help me. If somebody had a heart attack walking down the street, you'd be right there with a cell phone, and there'd be surrounding people, and everybody would be, doing the best thing they could to be helpful. Every time you walk by somebody who's psychotic sitting on a sewer grate, what do? Cross the street. So these disorders are actually, in some situations, for some patients, extremely difficult to deal with. The parents that dropped their kids off in Nebraska both were not able to cope with the child's illness. All of those kids, there are 37 of them. You know the story with Nebraska? They passed a law, essentially it's a safe haven law for children, that if you can't care for your kids, you can bring them to the fire station. In the same way that if you're a child who's abused or a spouse that's abused, you can go to the fire station and you'll be safe. So some of them drove as far to Nebraska, as far away from Massachusetts or Minnesota to drop their kids off. All of these kids, almost all these kids were severely mentally ill. Many of them had severely mentally ill parents who simply just couldn't cope. So I think that mental illness is actually a civil rights issue, and that we can think about it as a kind of medicalized evidence base. We don't have the evidence on it. But the stigma piece feels to me, like the women's liberation movement or the civil rights movement. The movement for racial justice is a social justice issue. And I think we're going to actually see, because the communities are getting organized. Just look at the autism community. They're not going to mess around with stigma. They'll haul people into court. And I think you'll see this more and more going forward. Please.
As you know, Duke and a lot of other places are getting involved in the from bench to community kind of advocacy. And most drug companies have drug salespeople that go out and do all the time. And I was wondering if you think there's a future where we're going to have best practice salespeople, so to speak, that are not necessarily out from the drug company, but maybe from the local university, that know what the best practice is, but use the same kind of sales techniques, go to the doctor, make doctor's office visits, and pump up the community with the best practice?
Yeah, it's a really good question. Is how do we sell evidence-based treatment? You know, it's a dissemination issue. Even apart from the funding stream, it could have a lot of people who just kind of drag their heels. So I think the best advocates for this are the patients or the sufferer communities. You know, they know how to find their way now because of the internet to the doctors who do evidence-based care. The systems of care can change out of altruism, or they can change because their funding changes. But people need to feel like they're doing something which they want to do, or put differently, leaders need followers. And the advertising industry is really good at selling you stuff you don't need. Some of that same technology. In fact, 99% of what we all buy we don't need. This is an aside. I mean, it's kind of odd, this stimulus, that you could actually let the world sort of downscale so that we spent less money on billion-dollar mansions and more money on, you know, housing for people who don't have a roof over their heads. If we didn't want to ramp the economy back up to where it was before. But I don't know how that's going to play out. You know, I think there's some movement toward using marketing-based strategies in mental health care. I mean, everything has now become a kind of a product to be disseminated. The difficulty is there's no payer for CBT. You know, you have enormous marketing machinery for the drug companies. Pfizer, for example, is now headed by a lawyer, and all the units are run by marketing people. There are lots of really good people at Pfizer. They make good products and stuff, but it's clearly a company like any other company. And that's true for most of industry at the moment. So they aren't going to go out and market CBT unless they can figure out a way to package it. Or the government tells them that in order to market a product, they have to include a psychosocial treatment package along with it. That may happen as a matter of public policy, in which case the question of how you do that educational aspect of marketing will become the province of the pharmaceutical industry, which will be to the better of patients, in my view. I don't think we're there yet. It's going to take intelligent public policy to make this happen. And we may see it in the last years of the Obama administration. I mean, he clearly has a science head on. He's got very smart people. We'll move to a national health system with an electronic health record probably within the next 4 years. And that's going to change everything. It's going to change the way we do clinical trials. It's going to change the way we think about mental illness, the treatment for patients who are mentally ill. It's going to change a whole range of things. Nobody actually quite knows how or what form it will take, but the fact of it is probably we can agree on.
I've got two questions. The first one relates to how you measure and define treatment effect, because I assume that the differential effect by different treatment modalities might depend to some degree how you constructed that scoring system and how you measure and define treatment effect. So if the scoring was constructed for an effect by behavioral treatment, you may have a worse effect on pharmacological treatment, etc., etc.
Can I answer that one? Then I'll
yes,
just
please.
So put a bit differently, it's if you have an effect size, say an NNT of 5, for one treatment in one condition, is that NNT of 5 the same thing for another treatment in another condition? And the answer to that question is, yeah, they're probably related, but they're clearly not the same thing. So a lot of the measures in the cognitive behavioral world, partly because the patients are different, the treatments are different, the endpoints were different, overestimate the effect of CBT. That's why these comparative treatment trials are so valuable, because they use the same endpoints. If you do something like the Clinical Global Impression Scale, where the anchors are the same across treatments and across disorder subgroups, then you can have a bit better sense that, in fact, you're measuring the same degree of improvement across patient subgroups. But it would be really nice to have to have a kind of more robust clinical trial, set of clinical trial endpoints. That doesn't mean the ones we use in psychiatry, even though they're all behavioral symptomatic rather than biomarker driven, they still are, for the most part, for most disorders, psychometrically reliable and valid for their intended purpose. People say that they're worthless and we shouldn't believe any of them, but I don't think that's actually true. On the other hand, the measurement issue that you brought up, reasoning across trials or reasoning across treatments or reasoning across patient disorders, that's a real methods question that could do with some additional work. If you're interested in that question and you're a statistician, I'd be glad to collaborate on trying to figure out how we can do something.
Unfortunately, I'm a mere cardiologist, but I'm just interested. So, but the other
I
question,
want to combine these data sets and try to answer some of these.
The other question relates to behavioral versus pharmacological treatment. Both treatment modalities, that the kids have to accept the treatments. So the smaller kids may not accept and don't want to undergo behavioral treatment, and the elderly, the teenagers may not accept to take pharmacological treatment. So how do you deal with that?
It's a really important question. If you look at the trials, like any clinical trial, it's a sample of convenience. The generalizable population and the accessible population all include patients for whom, for one reason or another, they wouldn't agree to be in the trials. So if you're a CBT kid and you and your family want CBT and you don't want to take the risk of being on medication, you won't make it into a randomized controlled trial that includes a med arm. There are methods for handling this called equipoise stratified randomization. We're using that in another study looking at treatments for ADHD. But it's a serious problem. What I argue is that we shouldn't expect the same effect sizes when you disseminate these treatments into practice settings as you get in these composed randomized controlled trials, which will almost invariably have better prognosis patients. Even in the practical clinical trials, they'll have better prognosis patients than you might find in clinical practice. So the effect size will be attenuated precisely because it includes people who don't want the treatment, who have all kinds of reasons for why the treatments might not work as well, who aren't as compliant with treatment, and so on. That's not a reason to not disseminate them. It's just a fact of life, and it's true in pediatric endocrinology as much as it's true in child psychiatry or pediatric cardiology. How we get better treatment adherence, more people to sign up for the treatment, is really important. And we have a junior faculty member here, Alfie Breland-Noble, who's trying to work on this in the African American community, where the issue of stigma is basically a huge reason why people won't seek clinical care and won't participate in research. So there are all kinds of psychological barriers that are related to this exact question that you're talking about. Can we trust our clinical trial results to generalize back to patient subgroups who aren't very well represented in the trials? And the answer to that question is probably not. And there was one more, right?
Yeah, I've just got a question. It seems the treatment response to anxiety almost exactly mirrors the treatment response to ADHD with anxiety versus just the treatment response without anxiety. Therefore, would it make sense to maybe call it anxiety with ADHD and put it in the anxiety section and keep ADHD without anxiety its own separate category?
Very good question. Very, very good question. And I'll tell you my sense of this is that the DSM-4, while it was a huge advance over what we had at the DSM-1 and 2 levels, which were basically all driven by psychodynamic thinking, the DSM-4 and the soon-to-be DSM-5, which in my view is a catastrophe of the first magnitude, don't actually reflect reality. They reflect a sense of constructs which hang together at the best, hang together on factor analyses from behavioral symptomatic data. And they don't actually at all capture, as pure constructs, most of the kids who fall on dimensions of these things and actually sit in the interstices, in the transitions between these things, which is the way the brain works. So is it ADHD or is it anxiety or is it ADHD plus anxiety or is it subsyndromal, this or that? I actually find these questions profoundly uninteresting and actually think they're a real obstacle to progress. This is not a criticism of the question because it's a really good question, But to the extent the field gets mired down in these kinds of things is which bucket does it belong in? These buckets don't correspond to the way the brain works.
Well, that's what I was thinking. I mean, maybe we could start, instead of just, categorizing the way we're categorizing, maybe categorize them with the treatment response.
Yeah, treatment response weighs into it. There are a set of criteria for how you validate a diagnosis, and one of those is response to treatment. If it was up to me, I would take DSM-5, put it on the shelf, and say, let's wait 10 years. Because once we understand the molecular pathways that are involved in particular sets of information processes that inform these disorders, we'll be a million miles ahead of where we are now in terms of understanding what it means to be mentally ill and how you got there. And then we'll be having a nosology, which is actually closer to the source of the problem, which is in dysregulated information processing in the central nervous system. So, one of the problems with DSM-5 is it's going to spawn a whole new industry of epidemiologic studies and longitudinal studies and treatment studies. And my God, what a waste of money. What a colossal waste of time and money. And it's because there are a lot of people still in psychiatry who actually don't want to sort of follow the revolution in neuroscience. They want to keep doing what they've done for the last 20 years, which has been really useful. But in the same way, we need to move to practical clinical trials and stop doing these big, expensive studies like the TADS. They serve their purpose and move to PCTs. The field needs to think about nosology in a very different way. And it's pretty hard to get somebody who loves green beans and hates broccoli to eat broccoli. And most of these people that are interested in this kind of nosological perspective are green bean eaters. And they just don't want to switch. Please. This is my not so humble opinion on that question.
I thought I heard you say that the suicides are usually when the kids are drunk or stoned.
About half the time.
Which is something hard to control in an adolescence population. Is it an independent predictor of treatment success, no matter what treatment you're in?
Very good question. Actually, I wouldn't say no matter what treatment you are in, but the general sense is that if you have substance abuse, it makes it actually tougher to make a diagnosis, and it enormously complicates the treatment. I mean, the NIAAA and NIDA have causes for their disorders, and these drugs of abuse profoundly change the way the brain works. I mean, if you take a dose of cocaine, within 10 milliseconds, you can see dramatic arborization and sort of strengthening of synaptic connections. Within 10 milliseconds of snorting cocaine, the reward centers in the brain are reinforced in a way. You can watch these little spiny neurons. You make more of them, and their synaptic junctions proliferate, and they have strengthened connections to their neighbors. One cigarette as an adolescent forever changes your brain. I mean, there's a reason why people take these things. If you think about what the impact of that is on all the other information processes that are going on in your brain, because I talk about these disorders of circuits and information processes, but the brain doesn't think like that either. It thinks as one thing, and it's completely coupled to the environment. We have this idea that we're in here and the environment is out there, but from the brain's point of view, it's like three-dimensional tic-tac-toe. Everything is completely coupled. In Asian meditation, it's called non-dual awareness. There's no inside, no outside, no past, no present, no this or that. It's all basically one unified thing. It's hard for us in our reductionistic models. They're really useful, but it's actually hard for us to think about this because our brains are, we're built to think in a cognitive way in terms of this and that. So, but if you think about substance abuse complicating depression, it's not like there's a substance abuse problem and a depression problem. There's just these information processes that are biased in one way or another, and substance abuse biases them in a way which is like throwing a very large rock into a pond. But there's ripples everywhere, and some of those ripples affect emotional information processing. Some of them affect your ability to say no, put a stop signal in place. Some of them affect your ability to problem solve. And all of these depend on these various information processes to regulate emotion. So, in a sense, it's a like H.L. Mencken said, inside every small problem is a large problem trying to get out. And when you interact causes, substances being one, genetic interacting with environment risk being another, you simply make for a very complicated problem. But it affects the same information processes. Okay, thank you.